My name is Shawn Depcinski. I'm an infectious disease and antimicrobial stewardship pharmacist. And today we'll be talking a bit about procalcitonin and how it's utilized in practice to kind of give you guidance in terms of optimizing its use and helping it guide therapy for you and your patients. So first we're going to start out with a brief introduction or overview of procalcitonin kinetics. In general, when there is a bacterial infection or some other stimulant to produce procalcitonin, typically you see procalcitonin rise within the first 3 to 6 hours from the onset of infection or significant symptoms or sepsis. And then from there, the levels will keep going up if uncontrolled. The procalcitonin will keep increasing. However, if potentially we have some antibiotics that are partially effective or ineffective, you may see kind of this plateau effect here that procalcitonin essentially doesn't go up much, but also doesn't decrease. Now, this can mean the antibiotics are ineffective. It could be source control issue or some other patient factor unaccounted for, and may require additional workup, testing, maybe a reevaluation of the treatment course. And then you'll see that with effective therapy, effective antibiotics, source control, things like that, the procalcitonin will start to gradually decline. Typically, because of a 24-hour half-life, you'll see it decrease by about 50% or so every day. However, there's always patient factors that may adjust how you see how rapidly it declines. So in this case, we can utilize procalcitonin cutoffs to help guide us determine if an ongoing bacterial infection is likely or not. And there's varying degrees of likelihood depending on the value. However, commonly we'll utilize a procalcitonin cutoff for lower respiratory tract infections of 0.25 to help us determine if it's greater than that ongoing bacterial infection is likely, and therefore antibiotics are encouraged. If procalcitonin, however, is significantly less than 0.25, bacterial infection is quite unlikely and antibiotics are often discouraged. However, antibiotic therapy should be considered regardless of the procalcitonin result if the patient's clinically unstable, if there's high risk for adverse outcome, or you have strong evidence for bacterial infection. And at that point, you can reassess at a later time to determine if antibiotics are needed depending on the trend of procalcitonin. If antibiotics are withheld, reassess if symptoms persist or worsen, and repeat procalcitonin measurement within 6 to 24 hours. In order to assess for treatment success and to support a decision to discontinue antibiotics, follow-up samples should be tested once every 1 to 2 days and based on clinical discretion and taking into account the patient's evolution and clinical course. So this is a case of a 65-year-old female with advanced COPD and diabetes who was admitted in December pre-pandemic to the general floor with fever, leukocytosis, cough, wheezing, and increased shortness of breath, requiring 4 liters per minute of oxygen via nasal cannula. Chest x-ray demonstrated a right upper lobe infiltrate, and therefore prednisone, bronchodilators, ceftriaxone, and azithromycin were started for treatment of presumed acute exacerbation of chronic bronchitis secondary to community-acquired pneumonia. Later that day, procalcitonin returned with a level of 0.12, and the influenza A PCR came back positive. Oseltamivir was started at that time, and antibiotics were continued due to a concern for bacterial co-infection. The next day, procalcitonin drawn with morning labs showed that it was still within normal range and actually a little bit lower at 0.09. The patient's fever and oxygen requirements were decreasing, so the antimicrobial stewardship team recommended stopping antibiotics, which was accepted by the primary team. Over the next 4 days, the patient continued to improve with oseltamivir and steroids and was eventually discharged home. Key takeaways here are that although bacterial co-infection may occur in at least 1/4 of hospitalized patients with influenza, procalcitonin has a high negative predictive value when utilized with a cutoff of 0.25 for determining the need for antibiotics in lower respiratory tract infections. When uncertainty exists with an initial negative procalcitonin, repeating the test within 6 to 24 hours can assist with confirming the negative result and indicate that antibiotics may no longer be necessary for your patient. So this is another great example where using Brahms procalcitonin in the setting of lower respiratory tract infection can help us in the differential diagnosis and determine that bacterial infection can likely be ruled out, and clinicians can help avoid unnecessary antibiotics and continue with appropriate antiviral therapy, which is one other way to help supporting antibiotic stewardship.